Our hospital was founded by Germany 120 years. So this year, we should have a very important ceremony later for. Thank you so much, CN, give me a warmly invitation, stand here to share my information. I'm no conflict of interest. A couple years ago, WHO showed us the very important mission to improve the patient's clinical outcome, how to decrease the mortality and the morbidity, improve the patient's quality of life, and shorten patients' hospital stay is a very important target. For gastric cancer surgery, we should perform the dedicated lymph nodes dissection because most case is advanced in China. More than 17% case have the lymph node deposition. And the GI tract reconstruction is also important. And extensive resection of the stomach, the positive, the negative margin play a very important role. So we should do a lot of work for the patient dynamic account mobility and the government's perioperative period. In our hospital each year, there are more than 1,000 cases of gastric cancer patients received different surgery. In recent year, the robot and laparoscopic surgery, the rate increased. So for the early stage, we also performed endoscopic, such as EMR, ESD. But for this stage, advanced, we perform standard D2 dissection for patient. The later stage, we need MDT, the conventional therapy for patient. So in my practice, my team underwent the surgery from 20 years ago. In that time, old story, we performed the very intensive surgery. Recent year, we performed the minimally surgery for patient, especially the precision surgery for patient. So we perform a lot of clinical trial under the standard. We published the Preoperative ERAS Part 3 for gastric cancer surgery, but the central part is precision surgery. That included disease assessment, the clinical decision making, the simulation planning before the operation, and the patient management. Also, we need the platform of surgery, such as robot, laparoscope, and energy devices. During the operation, it's very hard work to prevent the invisible damage, especially vascular image. So here is a new word. We are robourgent, right? The surgeon can perform the surgery, use a robot, is robourgent. Agree with me? We look for it. This is a black video of our experience. The hemorrhage bleeding or the blood vessel damage is a disaster for the patients. So the father of modern manager, Drucker, once said, the greatest danger in times of turbulence is not the turbulence, it is to act with yesterday's logic. It's right. So in our study, we performed and established a novel classification of celiac, SAMI, and the branch to the stomach, and to navigate the precision lymph node dissection by robot and laparoscope for gastric cancer patients. So we performed more than 300 cases of patients. This type, the trifurcation of CT trunk is very common. Most of the case is very safe during the operation. This type, the left gastric artery from aorta is another safe type. But type 3, the celiac and mesenteric trunk come from the same part. This is dangerous, is a risk factor for surgeon, is challenge. So the common hepatic artery aberrant on the superior margin of the pancreas. Type 4, the CHA from CTA or SAME, also aberrant of the CHA. And this type 4, CHA is from the SAME. This is another type of risk type. But this is very common type, risk type. The left hepatic artery arising from left gastric artery. So during operation, we can protect this branch of artery. This type 7, is very, very dangerous. The CHA comes from left gastric artery. If we performed the lymph node dissection, for example, number 7, we should make ligation for the left gastric artery, so the patient can meet disaster of ischemia from the artery. So we established a novel classification of celiac trunk and SAME. Type 1, type 2 is it's no risk type. 3, 4, 5, 6, and 7 is the risk type. So if we perform the CTA before the operation, the risk time, we should pay attention during the operation to avoid injury of the blood vessel. Here is the example. The CHA from SAME. The CTA, and during the operation, we used the robot. So on the superior margin, no artery, common hepatic artery, is only a portal vein. So we dissect the lymph node 8 and 11A. We should prevent the damage of the portal vein. So after the surgery, the field of surgery is very clear. The patient is safe. So we conduct the study for the patient. We divided it into 2 groups. One group, the patient performed CTA before the operation. Another group did not know CTA before the operation. This is a study flow chart, the PSM matching. So we compare the patient's clinical outcome and the duration of the surgery. We found that the lymph node was dissected increased in CTA group. The operation time decreased shortly in the same group. The blood loss decreased in this group, and very important, intraoperative blood vessel injury decreased remarkably. So, ladies and gentlemen, I should make a conclusion for the topic. The assessment used the CTA before the operation for the artery anomaly is very important for the planning and precision laparoscopic or robotic lymph node dissection. This method provides more anatomic basis and information for the real-time navigation in the future. You know, the high technology development very fast. So this morning keynote speech, the professors from French show us a lot of very important information about the navigation during the operation in the future. So we used this method to for the judgment of risk type of celiac trunk, and the SAMI may help to reduce the possibility of vascular injury and improve the patient's short-term outcome. But we should perform another clinical trial according to the standard to compare the patient's oncological outcome in the future. This measure should be improve the patient's the prognosis, for example, the 5-year survival or 3-year survival in the future. And this is the last salad. Another told us the very important story. Safety is no accident. So this is a patient complicated later rupture from the splenic artery after the surgery more than 1 month. Then my team performed a very important diagnosis and invite the DSA doctors to perform the embolism so the patient safe. So after my speech, I did not want to have the same dream from the message. My patient have the severe complications follow the surgery. No, the patient's safety and quality is my mission, our mission in the clinical practice. Thank you very much. Thank you.